Welcome. If you're working in the OR, you are, for all intents and purposes, the kidney's guardian. So in this explainer, we're going to arm you with everything you need to know to protect your patients, especially those with kidney disease, during surgery. To really understand the stakes, we need to start with just one number, and it's a big one, 25%. Just let that sink in for a second. With every single beat of the heart, a full quarter of all the blood goes straight to the kidneys. Now, this massive blood flow is what makes them such incredible filters, right? But it's also their greatest vulnerability. Any little hemodynamic shift we cause during surgery, the kidneys feel it first, and they feel it the hardest. So here's our game plan. First, we'll do a quick refresher on the core physiology that really matters to us. Then, we'll pinpoint the specific threats the kidneys face in the OR. After that, we'll talk strategy, how to prevent injury. And finally, we'll lay out a clear action plan for patients who already have kidney disease. Okay, let's start by zooming way in, down to the nephron. The best way to think about it is like a microscopic, high-efficiency factory. And get this, there are about 1 million of these incredible little engines humming away in each kidney. And this is the factory's assembly line. It all starts at the glomerulus, where blood gets filtered. But that's just the beginning. The real heavy lifting happens right after, in the proximal tubule. This is where the body grabs back almost everything it wants to keep. Then the loop of Henle works its magic, creating a salt gradient to concentrate the urine before the final, delicate adjustments are made further down the line. It's just a beautiful system of filter and reclaim. So you might be wondering, how does this tiny organ handle that insane blood flow? Well, it has a superpower. It's called autoregulation. As long as the mean arterial pressure stays in this pretty generous window, somewhere between 80 and 180, the kidney can basically protect itself. Our job as guardians is to keep the patient's pressure in that safe zone. If we let it drop below that floor, we're essentially starving the kidney. And if we look at the different departments in this factory, you see this perfect division of labor. The glomerulus is like the initial quality check, filtering about 1/5 of the plasma that comes through. The proximal tubule is the main production floor, doing all the bulk reabsorption. The loop of Henle is the specialist concentration unit. And the collecting tubule? That's the shipping department, making those last-minute adjustments based on hormonal signals from the rest of the body. So we have this amazing, self-regulating factory. It's incredibly resilient. But what happens when we throw a massive wrench into the works? The combined stress of surgery and anesthesia. This is really the core question we have to answer every single day, because the kidney gets hit from two sides at once. On one side, you have the body's own stress response. It's freaking out, flooding the system with hormones like ADH and aldosterone, basically screaming at the kidneys to hold on to every last drop of salt and water. And at the exact same time, our anesthetic agents and even physical things like a pneumoperitoneum can directly squeeze down on the renal arteries, choking off blood flow. It's a classic pincer movement. And the kidney is caught right in the middle. And that brings us to the most important part of our job, prevention, right? How do we build a defense? How do we stop an acute kidney injury, or AKI, from ever getting started? And we need to take this seriously, because post-op AKI is a huge and often overlooked problem. I mean, look at this. Sure, it's about 1% in general surgery, but that number skyrockets in sicker patients. And it can hit as high as 30% in big cardiac or vascular cases. That's almost 1 in 3. So our defense starts with being a good detective, identifying who's vulnerable before we even start. We look at their history, existing kidney disease, diabetes, hypertension. Then you add in the things happening right now. Are they hypovolemic? Are they older? Have they been exposed to any nephrotoxic landmines like NSAIDs or contrast dye? Every single one of these piles on more risk. The KDIGO classification gives us a standardized language to use when things go wrong. But what's really wild about this, what should really get our attention, is how sensitive this scale is. We're not talking about huge changes. A tiny little creatinine bump of just 0.3, or a dip in urine output for just a few hours. That's it. That's officially stage 1 AKI. That's our fire alarm telling us to act now. Okay, so let's get practical. This leads us to our final part, the clinical action plan. How do we actually adjust our anesthetic when we know our patient has kidney disease coming in the door? Our entire approach changes depending on how bad the disease is. For someone with mild to moderate issues, our number one goal, our only goal really, is preservation. We have to protect what function they have left. That means being obsessive about their volume and their blood pressure. Now, for a patient in end-stage failure, the horse is out of the barn. Our focus has to shift to managing all the other problems that uremia causes: anemia, acidosis, fluid overload, while being incredibly careful with our drug choices. And this is just such a critical point. It's easy to get hyper-focused on the patient with end-stage disease, but this quote reminds us that we can't let our guard down. That patient with just moderate insufficiency is walking a tightrope. Our anesthetic can either keep them balanced or be the thing that pushes them right off the edge into total failure. A huge part of this is knowing which tools in our toolbox rely on the kidneys to be cleaned up. And the list is long. It includes things we use every day, like certain muscle relaxants, our reversal agents, and even the active metabolites of common opioids like morphine. If your patient's kidneys aren't working well, the effects of these drugs can stick around for a dangerously long time.
So, what are the kidney-friendly drugs? We've got some fantastic choices. Cisatracurium is a star player because it breaks down in the plasma, no kidneys needed. Remifentanil is another great one. It's metabolized by enzymes right in the blood. And of course, propofol and our volatile gases are generally very safe bets because they don't depend on the kidneys for clearance either.
So I'll leave you with one last and really crucial thing to think about. That normal creatinine on your elderly patient's lab report, is it really normal? Remember, creatinine comes from muscle, and as people get older, they lose muscle mass, so their baseline creatinine production plummets. This means a number that looks perfectly fine on paper could actually be hiding a really significant, really dangerous drop in their actual kidney function. It's a powerful reminder to always look deeper than the lab value and to be the guardian for every single patient.